This hour, there's a 33-year-old man in New York City hospital who has manifested symptoms consistent with Ebola. And while he might end up in the same situation as 88 other suspected cases of Ebola in New York City since October 6th, most of which were easily ruled out, this man, Craig Spencer, is a doctor from Doctors Without Borders, having come from Guinea, one of the 3 affected countries in West Africa, where he treated Ebola patients. And that obviously puts him in quite a high-risk category. And New York City officials say he is being closely monitored in an isolation room in Bellevue Hospital, with test results expected by 3 a.m. What is truly remarkable about this story is how this case has been treated thus far, as a study in contrast with the botch case of the now deceased Thomas Duncan and Dallas Presbyterian Hospital. Over the past 2.5 months, America's largest, most crowded city, New York, has prepared, trained, and drilled for an anticipated Ebola case, putting in procedures and protocols for this very day. In full disclosure, my father works for the New York City Department of Health, but New York's preparations look to be truly impressive. At JFK Airport, according to a detailed account by Business Insider, travelers from affected countries are questioned, their temperatures measured with an infrared temperature gun. Bellevue Hospital is New York's designated facility for possible cases. It has 4 isolation rooms with 9 more rooms that could be ready if necessary. Learning from failures in both Dallas and in Spain, nurses in New York have been trained in how to put on and take off personal protective equipment. Additionally, the city's Department of Health has sent patients undercover, pretending to have Ebola symptoms and with a plausible travel history, into all 11 city hospitals to evaluate their performance. The CDC communicated a host of procedures to New York City hospitals, which put those procedures into place on August 11th. And so here's how all this training and preparation came together today. Dr. Craig Spencer, suffering from symptoms of 103-degree fever and nausea, called 911. Per protocol, Ebola was recognized as a possibility, and a specialized EMS unit was dispatched, with EMS crews responding wearing F-suits, which are hazmat suits that cover the entire body. Clad in those hazmat suits, FDNY hazardous materials specialist sealed off his 5th-floor apartment around noon, according to the New York Post. Video obtained from NewYorkPost.com shows Dr. Spencer being transported to Bellevue Hospital from his Hamilton Heights apartment in an ambulance with a police escort. EMS HazTac units transferred him, according to the New York's Department of Health. According to New York City Department of Health, Dr. Spencer's girlfriend is healthy and in quarantine. And just hours ago, New York Mayor Bill de Blasio addressed this possible first case of Ebola in New York City.
The important facts to know here, without going again into too much detail, the individual in question is a doctor, has been able to work very closely with public authorities in providing information. A very careful protocol has been in place now for weeks. This protocol was followed every step of the way, including the initial contact with the individual.
Joining me now, Dr. Devi Nampiaparampil, Clinical Assistant Professor of Rehabilitative Medicine at NYU School of Medicine. So there has been, behind the scenes, as we've all been watching this, right, there's been a fairly intensive effort and communication at all the hospitals in New York, because I think there's a general sense among officials that if it's going to end up anywhere, it's going to end up in New York.
Especially with all the flights that come into New York. I mean, people have been preparing for some time, and there's all the things that you mentioned, which I'm very optimistic about, but a lot of hospitals are actually going beyond that. So they've created some web communities. I mean, think about, in general, if you're trying to learn something new, some new technique, or if you have a question, you look on the internet, right? So they've created these online communities where people can get more support about how to manage Ebola immediately. And in terms of mock trials and mock patients, that's also a good thing.
So doctors, nurses, healthcare providers can go on a sort of message board and ask questions about, you know, how do you put on this piece of gear? What do you do if you have this person presenting these symptoms in an emergency?
Exactly. So people can get their questions answered immediately. And on top of that, just the way the Pentagon created its strike team, many hospitals have also created their own strike teams within the hospital of specialists. So if there's any question of anybody having Ebola, they can come and respond immediately and answer questions or take over care.
I was struck today about just in how this has played out. And again, I should say, you know, my father has been involved in this, so I've sort of been seeing it from behind the scenes at some level. But the importance of as early identification as possible, because what you had in Presbyterian, and which was a real screw up, was he comes in and gets sent home with antibiotics.
Of course.
What you have in Spain is a nurse just sitting in an emergency room, according to reports, telling people I have Ebola and not being put in an isolation chamber. The key is to find out as early as possible. It's impressive to me that they got an EMT unit equipped out to this
Exactly,
gentleman.
and that this person also didn't go to the ER. You know, he called and he let them know that he might have been exposed to Ebola.
That's the other side of it, right? This is someone who's come back from treating people with Ebola knows exactly what the risks are, presumably.
Exactly.
And is probably flagging it ahead of time.
Yeah, so the people in the ER did not get exposed. I mean, even the people who came to respond, the first responders were protected for the most part. So I am very optimistic about the way that was handled compared to other situations, of course.
You know, part of I think what we're seeing too is just a learning curve. I mean, and there was a lot of criticism of that initial response, and I think it was warranted because it was not handled well, and there's a man who passed away, possibly whose life could have been saved had intervention happened earlier. At the same time, Dallas Presbyterian has no experience with Ebola. I mean, in American hospitals in general, aside from these very specialized units in Nebraska and Emory and NIH, don't have much experience.
Well, and I think you're right about the learning curve, too, because in Dallas, I mean, I don't think people would have expected to see Ebola. And of course, we didn't have a single case of Ebola in the United States at that point, right? So here in this situation, we're learning from everybody else's mistakes. The CDC has already revised its guidelines. The Pentagon formed that strike team. So there are a lot of different things that are contributing to our having a better response, I would think.
There's also this practice makes perfect aspect. I was someone that I know who had spent time in Nigeria and in Kenya had talked about how she was back in the U.S. and had malaria, and actually the treatment wasn't great because her doctors don't have a ton of experience in the U.S. in treating malaria, whereas doctors in Africa actually do, in Nigeria and Kenya, and the two countries that she had been in. And I thought of that here, right? I mean, these are people who are going from zero to crash test in a very short period of time.
Exactly. I mean, I've always thought that we should recruit some of the West African doctors, especially the ones who have had Ebola in the past, Ebola survivors, because they can't catch it again. So why not draw on their expertise?
Dr. Devi Parampal, thank you very much.
Thank you.